Okay, welcome everybody to another edition of the DY Patil Postgraduate Lecture Series. We have been conducting this since the August of 2015, unflinchingly every first Thursday of the month, barring a few exceptions where we had to switch the dates for certain practical reasons. But otherwise, so far we have been having these lectures on a very regular basis, and I'm glad to say that we have received a lot of support, a lot of patronage, and a lot of encouragement from various faculties as well as all the young students. Today, we have another exciting lecture by Dr. Parag Shah, who's breaking it down to the absolute basics for all the postgraduate students, as well as for some of us old fogies who have forgotten our basics. So I will obviously uh, allow Dr. Kranti to introduce Dr. Parag and uh, tell us about him in a little bit more detail. But at the outset, I would like to thank Dr. Parag Shah and Dr. Kranti Kadam to have taken the time out of their busy schedules and been with us today, this evening, to help take this forward. And I welcome the both of you and all the young students who are with us today, and perhaps some other faculty as well. It gives me pleasure to introduce Dr. Kranti to all of you. She is an additional professor at the Department of Psychiatry at the GS Medical College and KEM Hospital. She has done her undergraduation from GS and KEM both, and she has done her post-graduation from the Lokmanya Tilak Medical College, Mumbai, and the hospital there. She has a teaching experience of 24 years, and she is a faculty and a postgraduate guide at the Maharashtra University of Health Sciences. She's presented papers at various national and international conferences. She's published papers in various national and international journals. She's received various Best Paper awards. She's a nodal officer for national and international projects of various kinds. She is a de-addiction specialist, and she is an executive committee member of the ethics committee at KM Hospital, and she's also a member of the domestic violence committee at the KM Hospital. So welcome, Dr. Kranti, and like I said earlier, I'm glad that you could make the time out of your busy academic schedule. And I now invite you to introduce Dr. Parag Shah and take the proceedings forward. Over to you, Kranti.
Good evening, everyone, and Happy New Year to you all. First of all, I'd like to thank Dr. Rasmin for inviting me as a chairperson for this educational activity, which is conducting since almost 8 years now, which is very helpful to all the PG students as well as the faculty. Today's topic is history and mental health examination, doing good, better, and best. Very important topic, actually, the basic ABC of psychiatry. Unlike other disciplines, where the imaging and the blood test will help, they help us to arrive at a diagnosis. But it's not like that in this discipline, where if you take a good history, if you are able to take a good history from the patient and the relatives, and if you are skilled at taking mental studies, at doing mental studies examination, then only you will be able to arrive at a particular diagnosis. So these are the best tools, and these are the only tools which we have in psychiatry for diagnosing the patient and for the better treatment. So to know about it in detail, we have eminent speaker with us today, Dr. Parag Shah, who is an excellent teacher, and presently he is holding the position of his professor and head Department of Psychiatry, Srinath Medical College, Surat, India. He is also EC coordinator uh, at IPS Psychotherapy Specialist Section, then IPS College Mental Health Specialty Section, Consultant Subcommittee, Community Psychiatry Specialty Section. He is also Zonal Representative of IPS West Zone Branch and President-elect IPS South Gujarat Branch. He's been President of IPS Gujarat State Branch, also Associate Editor of MS of Indian Psychiatry, and Editor of Indian Psychiatry Society, Gujarat State Branch. Sir is presently pursuing PhD and is DNB and MD. He has almost teaching experience of 20 years and around 25 publications he has to his credit. He also published books like a manual on poor school performance for parents, teachers, and health professionals, and communication skills for mental disorders. His areas of interest are in tobacco cessation, personality disorders, digital social media, screen addiction, and professional skills development. Sir is also a member of International Headache Society, Indian Psychiatric Society, Indian Association of Child and Adolescent Mental Health, and Indian Medical Association. So we don't have a better person than Dr. Parag Shah to talk on this topic. Over to you, sir, and thank you.
Thank you. Thank you so much, Dr. Kranti. Thank you for introducing me. At the beginning, let me thank Dr. Rashmin for this wonderful forum of PG teaching programs and inviting me today for this session. It's my pleasure, and I'm so happy to share and talk with all of you today. Thank you, Dr. Kranti, for chairing the session and for giving a background and the preface of the topic. I'll just start with sharing my screen. Okay. Is everyone able to see my screen and hear me?
Yes, yes, doctor.
Yes, sir.
Okay. Okay. Thank you. Okay. So, today's topic about the history taking and mental status examination, we all have been talking about right from the first day of a first year of postgraduate training program. But we have always seen that every college, every department and institute have their own method of teaching learning in post graduation. And there are so many things that we find differently being taught, practiced across various hospitals and departments. We have an experience of seeing how mental status examination is being followed across different institutes. As teachers and examiners, we have been seeing students present cases, especially the major cases in examination, and how they fare good or not so good, and what makes that difference. Not only academically, but exam performance, but also clinically in day to day practice when we see a patient, especially when we are going to take an in depth interview and have a diagnostic assessment of a patient when we are going to see the patient for the first time in an outpatient department and we want to know everything and have a complete picture and be confident enough of our clinical assessment skills, there are so many things that goes into what can be done better every time we do this exercise. So when I thought about this topic, I have certain objectives in my mind. I do not intend to discuss anything which routinely we have in history taking and examination classes and lectures. I would like to focus only on things which are specifically important to be focused or done a bit differently than the conventional ways usually we are used to. And that's what make our assessment skills more finer and precise, and our presentations of the cases more comprehensive and more appealing to the listener. So, to begin with this, let me start with the history in psychiatry. The first section, which we usually focus, is about the social demographic profile of the patients. Apart from everything else, there are two important points. One is about the residence of the patient, and another is about the mode of approach of the patient or the family to the hospital. So, what makes them come to the hospital today? at this juncture of the illness with this presentation. And suppose if you're going to admit the patient, what kind of admission it's going to be is something which is very commonly missed, not discussed much, but has a lot of relevance in understanding the patient's problem and overall the case as it is. So these are the areas which I would request all the students to keep in mind when they describe the first section of the history taking. Then comes the chief complaints. We know the origin, duration, progression, kind of the chronology. We first begin with the patient's verbatim report, and then we go to the informant's verbatim report. Both we should be enlisting the symptoms or the presentations or the complaints in chronological order. Sometimes it does happen that the patients may not necessarily give you the information as you want in chronology, but then it becomes our job while we write down the history, and it depends on the practice that we have done to how we draft the narration of the patients into a history record, especially when you're going to appear in major cases in examinations and present these cases. Finally, in front of the examiner, you're going to make a kind of a very lucid, systematic, step by step presentation. And in order to do that, the draft or the report of the history taking which you have noted down in your case papers have to be accordingly well structured and arranged. And the best time to do that is when you elicit the history. So, how do you get information from the patient, which you then organize, sequence according to the chronology, and then write down systematically while you make your notes, is something that we need to keep in our minds. Then it comes the history of present illness. So, when we focus on this section of the history taking, things to be kept in mind would include something like you begin from the asymptomatic phase, and it's like how you tell a story in a chronological manner that it began with this thing. Typically, the patient was fine before 7 years, asymptomatic, no symptoms, and then there were certain initial factors which led to the onset of the symptoms. So, what are these circumstances, factors, triggers, precipitating events? It can begin with a prodromal phase. It can begin with some social antecedent event. It can begin with a medical condition. Whatever plays a role should come first, followed by the symptoms that emerged gradually over a time, with the duration that how long they lasted, and then coming to the progression of each symptom, discussing in detail about how do you describe the symptoms, not only the verbatim report of the patient, but also how do you describe the qualities, the extent, the severity, the impact of that symptoms on the patient's life, level of impairment led by those symptoms, and what helped or what worsened, including any possible intervention for those symptoms, is something which is expected in discussion about the progression or the course of those symptoms. And when you end this complete narration, you should be ending with the current picture that from that point of time when it began till today, when you are examining the patient, what is the last picture or the situation the patient is facing? What symptoms, up to what extent, and how it is affecting his life, typically in the form of impairing his life or affecting his level of functioning in all the spheres of his domains. The reason why this is important is because when you see the diagnostic criteria of majority of the disorders, you would find that there is the mention of the symptoms or clinical features. There is a mention about certain duration, which is of important, and there is a mention about how it affects or impacts patient's life up to what extent. Everything is important in order to understand that this is a pathological phenomena or a diagnosable mental health condition which you want to bring home the point when you describe this condition. It is very important for all the students to remember that as you are describing these things, you are building up an impression or an image about the problem into the listener's minds or examiner's mind. The more lucid you are in your descriptions, the more systematic your flow of description is, the more complete picture you give to the examiner or the listener, the better and more convincing would be your presentation to them. Coming to the next section is the negative history. I always feel that this is something which very commonly a lot of students give a miss, and they're not very sure as to what to cover, how to express this part of the history. We need to be very clear that the purpose of negative history is one, patient has expressed certain symptoms or complaints. Not necessarily it would be everything that the patient is suffering from. There will be also a lot of things which they may not tell you from their side proactively, but are still present, and that becomes a part of the positive history. So, unless you ask from your side that, okay, you have XYZ symptom, do you also have ABC along with it? Because then I make a picture in my mind and a complete diagnostic criteria is being fulfilled for one condition. So, as you elicit the history from the patient, you would also start building up an impression about what probably the possible condition the patient may be suffering from. So, when you begin your negative history, usually you begin with filling up the gaps, the diagnostic gaps, which helps you to confirm the diagnosis, and other clinical features or related parameters which you need to ask and complete so as to have everything positive being elicited by you. Second purpose of taking a negative history is to rule out things which you doubt or which you should doubt. And for that, you should know what you should doubt. So there comes the importance of differentials. So for every clinical condition, we have to develop an acumen whereby we are able to make up our minds as to with this three chief complaints and with this extra added positive history that I am able to elicit, what meaning does it convey to me? What can be the possible different mental health conditions the patient must be suffering from, or some physical condition, or something else together being presented in front of me? So when I am thinking about this and working on my differentials, I want to rule out other possibilities. And for that, I ask directed, clear questions. And I get negative responses, which I need to mention in my history reports. This is very important, and this shows that the student or the psychiatrist is keeping all possibilities in mind, is taking enough pains to clarify and rule out all other possible things that can happen in this scenario. So negative history is meant to for this both purpose. Negative history includes eliciting the positive part as well as ruling out the negative part. Typically, there are a lot of areas which we generally ask in almost every patient for negative history. But this is something that you should be asking to all your patients. One, history of self-harm. Second, history of substance use. Third, very common comorbid conditions. Like if you're a patient of depression, we know that theoretically anxiety disorders are the most common comorbid disorders with depressive disorders. So you're expected to ask all these comorbid commonly found conditions. You need to not forget that when a patient comes to a psychiatrist, it's not just a patient suffering from psychiatric disorder. He may be having one or more than one medical conditions, which can also be presenting in front of you in the form of some medical complaints. So we need to ask clear questions in order to confirm or ruling out that part of the medical or neurological history. And also anything that helps us to confirm about a possible personality related issues, any traits or any disorders or any criteria fulfilling in that directions. Going further in negative history, we will be talking about it later on. But before that, let us talk about the importance of eliciting the history of stresses. As I said, at the starting of the ODP, the onset, we do mention about the triggering or precipitating factors over there for each symptom. But apart from that, in this section of the history, it is very important in general in psychiatry, as we understand, that the weightage of the kind of stresses that the patient is living with on a long run, chronic stresses, or any acute stressful situation that the patient may be facing at the beginning of the illness, or maybe today when a patient is in front of you and you're eliciting the history, comes under this heading of acute or chronic stresses. They have their own significance, and a very clear report of this has to be conveyed to the examiners. And how do you correlate the presence of that stressful situations with the current possible psychiatric diagnosis and the presentations? It may have a relation, it may not have a relation, it may be leading to this condition, it may be contributing, it may be exaggerating, it can be influencing the course of the illness. There can be various different kinds of correlations that you can establish between a stressful life situation the patient is faced and the psychiatric condition the patient is having. After that, in the section of past psychiatric history, one very important thing which a lot of students undermine the importance is the inter-episodic period. And this is typically what 50% of the examiners asks from their side when the student reports about the past psychiatric history. So when you talk about what has been happening in past, similar episodes or other kind of conditions patients may be suffering from, and when the examiner is trying to imagine the longitudinal course of the illness, right from the first episode till now, we all know that it's not just the symptoms every time, the duration, the severity every time. But classically, in order to differentiate the possible diagnosis, we need to work on the inter-episodic periods also. How was this inter-episodic period is a very specific inquiry that we expect students ask to the informants or maybe the patients when they elicit the history and report very categorically when they present their case. Okay, similarly, there is a section of medical history. What we see is typically there is a fixed format, fixed questions that students are used to ask every patient and narrate the responses or inferences when they present the case in a very stereotypical manner. As a psychiatrist, if I'm listening to your history, I will be interested not just you discovering a medical condition or getting some basic details about it from the patient, but also how do you understand this medical condition in this patient and a possible psychiatric diagnosis interacting or correlating with each other. So, all kinds of possible correlations that this patient with an existing medical condition. Say, for example, if I have a patient with major depression and I'm trying to understand and assess, I get a history that the patient is having diabetes mellitus for last 10 years and he's on insulin treatment. I need to understand that how all both these conditions may be correlated. One, is it diabetes leading to depression for last 2 years? Is diabetes aggravating the depressive symptoms, or what is the symptoms of feeling fatigued, listless, lethargic, or the cognitive dulling? is not actually a symptom of depression, but a symptom of uncontrolled blood sugar? How has been the overall glycemic control in last 10 years, and how do I expect the brain being affected, the neurovasculature being affected, and we know that it can lead to major depression? What has been the patient's level of care, self-care, treatment, compliance, and adherence to chronic medical conditions like diabetes mellitus? That gives a lot of information to me about how patient is going to take the psychiatric history and how possibly various fluctuations in the mood that the patient is reporting can be correlated with the fluctuations in the blood pressure the patient may be having. There was some episode of sudden falling down and losing unconsciousness. Do I ascribe it to the medical diabetic history, or do I consider it a part of depression with some other anxiety or other symptoms? How does my treatment of depression going to affect the diabetic control? How the treatment for depression and the treatment for diabetes are going to interact each other? Would my treatment for depression, like maybe beta blockers, going to worsen the diabetes or maybe going to affect the presentation of diabetic symptoms? Everything goes in my mind and everything makes a sense. And it is important that this exercise of getting these details, basic details, up to certain extent that the time permits, I'm able to do that homework. I have a record in my case paper and I'm able to present these things. Not every patient that you are going to present or take a detailed history are going to come with all these things. But depending upon the patient, if somebody may be having a strong negative history, somebody may be coming with a family history, somebody may be coming with a medical history, but whatever is there, those sections needs to be worked up well in your reports. Okay, talking about the negative history once again, one way that I can suggest to all of you is have a very ready-made reckoner or a list of things that you know that you have to look forward or ask in the negative history. So when I know that I have most commonly major psychiatric disorders like XYZ being presented by me or being taken up as a major or a minor case in examinations, I know that with this major psychiatric disorders, what all goes and what all things I have to cover when I inquire about negative history. So if I do my preparation well, and if I know what to ask, what to confirm, and what to rule out, the job of eliciting the negative history becomes very fast and accurate. Something like for patients with major depressive disorder, my first thing would be to try to elicit the remaining symptoms of depression which the patient has not reported. Then try to inquire about the manic phase, the subtypes, the severity of the depression, medical associations, possibility of psychotic symptoms, substance use, and comorbid conditions in psychiatry. So if I know these are the 8 or 9 things I need to ask, my job becomes easier. So such kind of preparations whereby you know what to elicit, you can do your job very fast. Patients with schizophrenia, first thing I'll be doing is filling up the gaps. All the remaining part of the positive history, I'll confirm and I'll note down. Then, what all things I need to confirm and clarify and ask is all the positive symptoms, negative symptoms, catatonic features, cognitive features, mood features, substance use, medical associations, comorbidities, possibility of developmental disorders and personality disorders. I have included these things specifically because this can be either the part of this major disorder or they can confuse you, or the symptoms are very common or identical between these conditions, and you need to rule out them. So either they are comorbidities or they are similar presentations, or they help you to understand all possible associations that this major condition can have. For bipolar disorders, first thing is to complete the remaining positive symptoms. Then you need to ask about all the depressive phases, of course, the manic phases or hypomanic phases in the past, subtypes, severity, psychotic symptoms, medical histories and associations, substance use, and common comorbid conditions that you expect and you need to ask every patient of bipolar disorder. For patients with alcohol use disorders, the remaining symptoms of history positively, other substances that the patient may be using. And typically, a lot of students they miss tobacco and the history related to tobacco because somewhere we do not consider that as equal as other major substances. Comorbid conditions, which are very common, psychiatric conditions that are very commonly found with alcohol use disorder. Complications, all possible complications you need to rule out. Medical history, commonly we know what all to see and ask in alcohol use disorders. The other areas of life which are very significantly to be inquired in alcohol use disorders, like social life, interpersonal areas, occupational life, legal areas, accidents. So these are the expected things that an examiner or a listener would like to hear when you say that I have inquired and ruled out these things. If you have a case patient of obsessive compulsive disorder, apart from the remaining positive symptoms, you need to ask about other anxiety disorders. You need to ask about psychotic disorder. You need to ask about mood disorders, comorbid conditions commonly found to be associated, the medical conditions commonly found to be associated, substance use, something like tick steroids, obsessive compulsive personality disorder. So this is a kind of a short list that helps me to understand that how to go about when I try to elicit the negative history in my patient. Okay, going to the family history section. Family history is again something which is very important in over the span of many years of working in psychiatry. We know that families have huge impact. There's so many things that we can understand about the patient and about the disorder when we have enough information about the family. And they have a very important role to play at every stage, right from sharing the same genetic load to the burden of care that the patient may be generating because of the illness onto the family. So I think most of the psychiatrists would be wanting to know and have a very clear picture about the family information. Most of the students usually cover topics like the type of family, size members, familial environment, and also the presence or absence of psychiatric disorders, substance use, history of suicide, or sometimes the medical conditions in the family. Apart from that, there are certain things which I feel are very important and should be included when you report about the family history. One, the medical history, treatments taken, and the causes of death in the family. Very important because I expect my psychiatric disorder being inherited or the genetic loading in my patient, along with the genetic loading of diabetes or hypertension or arthritis being inherited by the patient from the family. So when I'm trying to understand my patient, I'm also interested in knowing about the medical status and the vulnerabilities that my patient does have. Because when I'm going to start olanzapine after 5 years, when I see my patients developing hyperlipidemia, I know that the family has a history of myocardial infarction, and that makes sense to me. The present relationships that the family shares, a lot of things to do with stressful life situations, a lot of things to do with the support system, a lot of things to do with how I plan my management. Yes, the overall support system in the family, how it is. It's not just the number of members that matter. It's not just the proximity of the relationship or being available in the house that matters, but the quality of relationship and actually the role that they are currently performing as a caregiver and how well, effectively, the support is being received by the patient. Ongoing stressors in the family, just like the patient has a history of stressors, the family also share common stressors, which are part of the patient's history and also family's history, and that does matter. The living conditions, the income sources, the affordability of the family, very important when you plan the management. It's not only the stressful life situations, but also the short and long term management plan that is based on those parameters. How has been the attitude towards the patient's illness? And what has been the impact of the illness onto them? Are they facing the stigma, the shame, the guilt? Are they finding themselves responsible for the problem? Are they having issues with taking care and they are not able to work or not able to live a normal, healthy family life because of patient's illness? Overall, the personalities and the intelligence levels of the family, because then I know how to provide the psychoeducation accordingly and what to expect and their contribution and role into the psychopathology and the process of recovery. Everything, because when we think about management of psychiatric disorders, lot many of our patients actually we work more with the family rather than the patient directly, especially in psychotic illnesses. We have to spend so much of time discussing about the management and their role and contribution into not only ensuring adequate pharmacotherapeutic care, but also everything else that goes into the process of recovery mainly comes from the family, and they are the major backbone for the patient's treatment in our society. And so, realizing their importance and understanding all these parameters and aspects makes sense for us when we try to understand the patient's picture. Okay. Then comes the section of personal history. So when I talk about the personal history, again, sometimes some of the students they go into the details, not all of them. After that comes the early childhood history, which is fairly well described by most of the students. When you go to the middle childhood history, it's important that there are certain things that you're specifically looking at. When we talk about the middle childhood history, what you're interested in knowing is how has been like right from 5 6 years up to 14 15 years of the life of that person and how they have spent that time with the family, with the schools, with the siblings, with the peers. And typically I've just enlisted a list of various neurotic traits that becomes a part of middle childhood history or maybe childhood history in some of the patients, like maybe OCD, maybe anxiety disorder, maybe personality disorder, any kind of case that we are seeing, we need to correlate and find out that this kinds of traits that the patient may have today have something to do with what they have been in their childhood. And that's the importance of this part of the history. When we're trying to inquire about how their adolescent phase have been, we want to know especially about the kind of relationships they shared within the family and outside their family. Areas like how have been their secondary sexual characteristics, how have been their uh, hormonal changes, how have been the puberty related changes been experienced and expressed by them, how have been their same gender and the cross gender relationships been developed and maintained during adolescence, the level of sexual activity, what all things and their attitude towards their own self and the opposite gender goes into understanding about certain aspects of the patient that makes sense depending upon the diagnosis. Especially, you need to inquire about their productivity or their efficiency in their tasks, schooling, education. So, the two most important things which we are interested in knowing is how were the relationships inside and outside the family, and how was overall the academic performance, or were they able to give justice and do what they are capable of. Because we see that the onset of a lot of major psychiatric disorders starts from adolescence. If not in the form of full-blown illness, maybe prodrome. If not a prodrome, maybe some subtle changes in the cognition, maybe in their behavior, certain domains of their mental health, starting very early in the age. So, if we are able to elicit and find out certain things going on at that point of time, it makes a good information for us to finally conclude what they may be having today. Going through the remaining parts of the history, the educational history and the occupational history, again, what we have been observing is that Very commonly, students have a fixed formats about what all information to elicit and report when they present the case. These are very important sections because these are the areas that we understand would be grossly affected in the details of how they are affected, in what ways, to what extent, how frequently, how long, and everything related to it helps us to understand the impact of the current symptoms onto their lives. Yes, the menstrual and obstetric history is again one area which many a times is missed to give its due importance in the history presentation. Apart from other typical history like RMPL and other things that the students do, you need to keep in mind about eliciting the history of the last period in every patient, female patient that you have. Second, you need to see and inquire if it's a woman of childbearing age. Is there any plan for pregnancy? This is a very important question, even commonly missed by clinicians in their routine work when they are trying to make a management plan for their patients. A habit of asking these questions to all your female patients of childbearing age is very vital, and we all know why it is so important. Going to the section of the marital and the sexual history. Yes, this all should be part of the general history, psychiatric history examination formats. And we need to go into details of this because we know that the sexual health very commonly associated with so many psychiatric conditions and a general idea about how they have been before and now gives us an idea about the impact of the mental health on their life. So premarital history as well as the marital history and the gender related questions, orientation related questions, and possible dysfunctions, not necessarily after starting treatment, but a lot of psychiatric disorders themselves can also change the sexual functions and capacities of the patients. Okay, legal history is again sometimes missed by the students, but which makes sense. Something like when you have a patient with substance use, when you have a patient with schizophrenia, when you have patients maybe with personality disorders, you need to ask about this important area. Pre-morbid personality. There are different formats, there are different things that are being practiced to discuss this part of the history. I have tried to enlist a kind of various factors that can be possibly inquired and reported when you inquire this part of the history. It can be something like covering the interpersonal relationship. So before everything happened, before the onset of the first symptom, how was the person, as an individual? When I try to meet that person, when he is a normal person, asymptomatic, what impression do I gather and what image comes to my mind is the pre-morbid personality that I am narrating about. So how do I describe that person? Based on the interpersonal relationship that that person had, predominant mood, most of the time how that person would have felt and expressed. Reaction to stressful life situations. So how has been those person always reacting or responding to stressful life situations? Otherwise, when he was absolutely fine. That gives us a lot of information about the person's basic profile, his capacities, his adaptive capacities, coping mechanisms, the role of stressful life situations into causation of the current illness, how after the start of illness those stressors may have affected, and the future plan of possible relapse prevention or worsening of the illnesses because of the stressful life situations. Attitude towards oneself and the others, attitude towards work, responsibilities, their effectiveness, their productivity in various areas of education, occupation, how they spend most of the time. Otherwise, like they have some interests, some hobbies, some skills being developed and practiced. All this information, bits and pieces, helps us to understand and create a kind of an impression about the person in our mind. no doubt about moral attitudes, religious beliefs. These are different sections, may not be relevant or important in every patient. But suppose if I am having a patient with personality disorder, I have a patient with alcohol use disorder. Maybe this questions may make more sense to me when I am going to elicit a premorbid personality. And typically, there are certain terms that I can practice, I can rehearse and try to remember which I would like to use to describe this person's when I'm going to talk about their personality. Like this shy, introvert, extrovert, social, outgoing, friendly, and others. See, what happens is for so many such terminologies which we otherwise know, in a very short span of time of eliciting history and presenting in the examinations, we tend to use our English language vocabulary in the best possible way, but we may not be able to have the specific and the best possible word to describe what we mean to at that point of time, especially when we are under a lot of stress and there is a lot of time crunch. The more you practice and rehearse these terminologies and adjectives beforehand, the more easily you will be able to remember and recollect and express during the examinations. Okay. For the general examination, yes, apart from everything else, what we do, we know as a psychiatrist what is most important for our patients to be examined. I'm sitting in a psychiatry OPD seeing 25 patients every day. I know there are certain things I would like to examine in my patients very commonly. If it's a patient of schizophrenia, I would like to definitely check the weight. If it's a patient of depression, I would definitely like to measure the pulse and the blood pressure. If it's a patient of substance use, I would like to examine most part of the body to see for any possible injection sites, mark sites, or any other scars or anything like that. Maybe borderline personality disorder would also present with typical scar marks somewhere in the body. So, depending upon the kind of major psychiatric disorders, there are relevant general examination findings that are possibly present, and you need to confirm and rule out their presence in your general examination. So, when you try to practice your history and MSc in your everyday life, you have to develop a checklist or this kinds of things that you are definitely not going to miss. Something like a mark of injury, something like patients with substance use, I would like to see the oral cavity. Patients with tobacco use, I'd like to examine the oral cavity. So certain things which are relevant should never be missed and are very important for you when you do the general examination. In systemic examination, every other system is fine, but the CNS, you need to go in a bit detail, even in a major psychiatric disorder. You're expected to have examined the central nervous system in detail. Time may not permit, but it is expected that if at all the patient has any positive findings, you should not be missing it. Something like any involuntary movements, something like rigidity, side effects of psychotropics. So there can be so many things which are expected to be coming out positive in central nervous system examination, even a patient of depression or schizophrenia. And it is wanted that you should have done, examined, and you report under this section. Okay, now coming to the mental status examinations and various areas that needs to be covered under them, let us focus on certain things which I would want you to specifically go into details. Apart from the general appearance, eye-to-eye contact and rapport, then comes a section which is called as attitude towards examiner. Again, prepare a kind of a list of adjectives or terminologies that you would remember, rehearse, and actually reproduce well during your examinations to describe that specific attitude. Something like a list: cooperative, attentive, interested, guarded, empathetic, disinterested, defensive, hostile, and others. So it's very important that you know these words, that you know what do they mean. So when your mind knows this, your eyes would be able to see it in the exam. or when your eyes would be able to see it, your mind would tell you what it is. When you describe about the motor activity, there are certain things which we would want you to specifically describe, like in various sections, like increase, decrease. You use various terminologies like state of excitement, restlessness, agitation, withdrawal. You do ask, or I would say, look for and report about any compulsive acts or rituals being practiced by the patient. Catatonic features in this section, tics, tremors, mannerisms, stereotypies in this section. Any akathisia, rigidity, slowness, dyskinesia of patients with schizophrenia, hallucinatory behaviors. So these are the things that are covered and can be reported under this section of the MSC. We know that these are present, but sometimes we do not report appropriately under the appropriate sections. Then comes the speech and then comes the mood. So when students try to elicit and report the section of the mood, what is expected is that for everything they need to tell what questions they asked, what was the response of the patients, verbatim, word by word, and thus how do you infer what you infer from that observations. Mood should cover various headings like the quality, predominantly most of the time, the depth or intensity, fluctuations or lability, reactivity to the environment or stimulus, persistence, consistently remaining like that, and the duration. When you inquire about the effect, similarly, you have to describe that what you observed and so what you inferred for different things. When you discuss the effect that you have observed, you need to cover different headings like the quality that you have observed, the range of expressions, which mean either it is broad or it is constricted and restricted. Second, the depth or the intensity that shows the amount of the expressions, and the words that you can use can be either it is more than average, normal, increased, or it is a less shallow, or it's completely blunted or flat. Lability or changes with time, congruence to the mood, and then appropriateness to the overall context. Context would mean the thought process of the patient and the environment and the milieu the patient is in. So when I know that these are the things I need to cover, when I remember these headings and I elicit accordingly and I report and I then express in my presentation accordingly, I am trying to cover and make it precisely what is expected by the examiner. Similarly, in the thought examination, I need to tell what questions I asked to check various sections, what was the response that I got, and so what inference do I make in the section of the stream of thoughts, the form of thoughts, and the content of thoughts. So, what I have tried to do here is I've tried to list various things that I'm going to take care of, or various terminologies that I may be using to describe that observation in under that section. Sometimes we forget to ask or note down certain things, even though we have observed. So, making this kind of a checklist can help you to not miss all the observations and put them appropriately under appropriate sections. Okay. One thing again in perception, when you discuss about the hallucinations or illusions, there are things that examiners commonly want to listen in detail. So every observation of an hallucination or illusion have to be described in a manner which sense, whether it's an elementary or a complex hallucination, what is the content, what is being typically heard, verbatim report of the patient, how many voices, male, female, How does it start? How does it stop? How long does it last? How many times in a day does it happen? And in what circumstances does it commonly occur? Is it second person, third person, command type, running commentary type? And how does the patient give a reaction to it? Something like an hallucinatory behavior, or he's distressed. Are these hallucinatory experiences both congruent or incongruent? So if I have this checklist, if I know that these are the things that I need to ask, this is a very concise form of me eliciting and reporting in a specific systematic manner. Going to the cognition area, again, I follow the same dictum. What questions I ask, what are the responses, and what are my inferences? One typical thing which every student needs to remember, and they commonly make mistakes, is when I try to elicit the fund of knowledge or the level of intelligence from my history and examination, I need to rely on relevant educational and cultural background. I should not have and I cannot have this common, typical, predefined questions to be asked to every patient in the same manner. So I have to apply my minds that for this patient, this level of education, understanding, background, and culture, this question would be an appropriate check to see whether he knows well about that subject and how has been his experience being observed by me and discussed based on my history taking with the patient. Again, in the section of describing the insight of the patient, it is important that not just grade in the details, you also have to tell that what questions you asked, what was the response, and so you infer the insight to be of so and so grades. See, for what happens is many times a student can have their own inferences, not necessarily based on a sound groundwork. So just telling the inference to the examiner does not bring trust or confidence into the examiner. Sometimes the questions being asked by the students are faulty. So the examiner wants to know that have you asked the right question? The examiner wants to know that whatever your inference is based on what response. So what was the exact response? Tell me. I would try to have my inference and I would try to match my inference with your inference, and thereby I have an understanding that what you have interpreted is the right thing. So this is what the examiner is looking forward when you narrate the mental status examination findings in your presentation. And that's the reason why you have to tell all these things. Then comes the aspect of judgment. Okay. Now, apart from this typical history and examination sections, there are certain things which I think brings about credit and helps you to make a very comprehensive picture of your patient when you are presenting. One, that section or topic is about impulsivity. So every major case, you have to comment on this section. What is your observation? Another is about the risk assessment. Not every standard history formats or performers do cover these things, but these are very important things for every patient that you're going to assess in detail. And it makes a lot of sense in understanding the problem, diagnosis, and management plans to make. So, risk assessment, how to do, what questions to ask, how to infer is something that you should know. Patient's reliability. Patient's reliability with regards to what they have reported to you. Patient's reliability with regards to how you plan your management and how you expect them to participate in the treatment process. Overall compliance that you predict, or how is your judgment about patients' compliance based on their past records of compliance, based on their current clinical condition, and your interaction with the patient is your judgment, and that's what is important to know. Okay, there are concepts like diagnostic summary, diagnostic formulation, case summary, case formulation, very commonly coming after at this part of the juncture in presentation after you finish your mental status examination. So you need to be very clear what do they mean and what is expected from you. Suppose if there is a very directed question coming to you that tell me about the diagnostic formulation in this case. So in general, the concepts goes like a detailed presentation and presenting everything in general is a major full case presentation. But when somebody tells you that, okay, I want to know the diagnostic summary, what does it mean? It means that you have to tell all the positive findings, all the most important findings on history and examination of the patient. You have to tell them about the possible diagnosis and the differential diagnosis. And what do you understand that what were the possible causative mechanisms, biopsychosocial, leading to what kind of symptoms or clinical conditions, and then the presentations in front of you. Diagnostic formulation would not include positive history, major components of history and examination. It would just include information about how you understand what the patient has, why they had that, has this, and overall, how do you plan to manage those things? So, diagnostic formulation would include that, okay, I find that in my patient of major depression, biologically, psychologically, and socially, these were the factors which have played role leading to this condition, which is of this type today. Possible differential diagnosis or comorbid conditions or nothing. This makes my diagnostic formulation. So when I add the plan of management into my diagnostic summary, it becomes a diagnostic formulation. In sorry, it becomes a case summary. And when I add a plan of management into my diagnostic formulation, it becomes case formulation. So when you are expected to give a complete case summary, you have to go up to a level of your plan of management. And when you are expected to give a kind of a diagnostic summary, you have to stop at the level of your diagnosis. Okay. Another sections which are important at this stage for you and expected for you, from you to discuss and describe can be the kind of a multi-axial diagnostic system which was there. A lot of examiners and listeners would want you to understand the problem in this regards. You're expected to have a fairly good idea about what do you think is the prognosis of this patient, what can be the different kinds of investigations if you need at all for this patient, which should include not only medical investigations, psychometric investigations, and also various rating scales that you would like to use for this patient for diagnostic and monitoring purpose. Again, for all this, you have to discuss what do you want to do it today and what you are going to do it in the later part of your management as a part of monitoring or follow-up. So taking a kind of a bird's eye view about, say, for example, the case formulation, or I would say a kind of diagnostic formulation. What it takes is at the end of this exercise, a student is expected to have a good idea about what biological, psychological, and social factors may have played role in causation of this current clinical condition. And accordingly, when you are asked about your management plan in this patient specifically, how would you treat or manage? Your concepts about addressing the biological factors playing role with use of psychopharmacology, ECT, and other medical treatments, your concepts about addressing the psychological factors playing role by use of counseling techniques, therapies, and various other related interventions, and your concepts about addressing the social aspects of this clinical condition with use of psychoeducation, vocational training, social skills training, rehabilitation, stress management, and other areas in your management plan makes us believe that you know exactly what comprehensive care means for your this patient. Again, how do you understand your management plan with regards to your intervention today, right now, as a short or an acute term management, immediately or in the next few days, what you plan to do in biological, psychological, and social. At the same time, based on your long term prognosis and anticipated course and the need of this case, how do you plan your long term management biologically, psychologically, and socially for this patient? Is something which you would be very happy to listen. Goals of treatment is something which can be expected from you by the examiners. So, what can happen is that one of the examiners can ask you that, okay, with all these treatment plans, what do you think would happen? What would be the outcome of the treatment or intervention? So, based on our experience and based on the profile of this patient, what do you judge? So, this is clinical judgment. And the examiner wants to know, based on your experience and practice of psychiatry, seeing patients, reading theory, applying those theories in everyday practice, and what you have gathered in those experiences, how much clinical discretion or judgment have you developed to predict the course, and what realistic goals of treatment do you plan to achieve in the coming time? Affordability of the treatment is very commonly missed by so many students when they are asked specifically about how you are going to manage this patient. We see a patient which is a poor farmer from a rural background, and we can see that they're not going to afford certain medications or treatments. And we see that there is no understanding or planning for this aspect of the care when your student discuss about the management need or situation like involuntary treatments, if at all, how, what, and a lot of legalities comes into the picture when you have to discuss this part of the management. It is important that you narrate about your plan for monitoring this patient in acute phase and in the maintenance phase of the treatment when you tend to finish your management plan discussions. It's also important that it's not just the patient. Your management also includes one of the important stakeholders, the family, as we discussed in the family history section. A lot of things they can do, they have to do, and we have to get them involved. And what all you are going to do with them? Are you going to educate them? Are you going to work on their attitudes, their practices, their experiences with this mental illness? What is their level of understanding? How much they are able to comprehend? How you're going to make them understand the whole problem? Are there any expressed emotions? Are there any burden of care onto the patients? Are there any family history of the similar psychiatric disorder and the family is to take care? So, how everything is going on at the family level, and how do you plan to address that aspect of the patient care is something which should also be a part of management plan. Not to forget long term vocational therapy, rehabilitation, any possible disability that the patient may be having today, and everything that you need to inquire and confirm for the disability status. And also, whom do you plan to refer this patient for what purpose is also an essential component of management. So if you look at this headings and subheadings, you would see that it's almost everything that we do otherwise in our daily practice. But when I want to put up in a single page, in a single case, in my single presentations, I need to compile these aspects. So we need to practice everyday history taking an examination in this manner that we include this headings and subheadings, and we practice in every patient whatever is applicable in that respective patients. We go into the details. Then and then only you will be able to remember and perform well accordingly in your examinations. So before I end my presentation, I would like to say something. Uh, Typically, a good presentation from a student would require a very good preparation for history taking. So this whole presentation, which I tried to narrate, is something that would add or would confirm what you are doing is a good history taking. It helps you to make it a very, very clear, concise, yet comprehensive, a lucid picture about what the patient is, what the problem is, and how do you understand the whole problem, and how do you, as a treating clinician, address the whole problem. So you can do that in a short span of time in examination only if you have made notes, if you have practiced enough, if you have made good preparations for history taking. Remember that your eyes would be able to see only what your mind knows. So have all the concepts in place before you start looking for it in the patients. You need to have a very good verbal skills, written skills, and a comprehension skills. A lot of us, we come from different educational backgrounds, not necessarily very comfortable with English language to express ourselves, but it's very important. A good presentation includes a good English language skills. Yes, that's what I mean. A good presentation does mean a good presentational skills. So how you use your verbal, your non-verbal communication when you present your case? What words do you use? How you form your sentences to express yourself? Are most of the examiners able to understand what you say? Are you able to judge that? What happens is many a times, lot of examiners may ask you questions in their own ways. Not necessarily all examiners are optimal with regards to their English language skills or communication skills. And sometimes it's not very clear what the question is. It's not very clear what they intend to ask. And thereby, there is a gap and confusion and a lag and a pause in the presentation, leading to a lot of confusion on the student side, on the examiner side. And it leads to a lot of uh, unhappy situation that we face. So when you are sitting on one side of the table as a student and presenting a case, you also need to learn to improvise your skills to comprehend and understand that if the person on the other side of the table is asking something like this, what does it mean? This comes from your ability to interact with your teachers, your examiners, your seniors frequently, time and again. The more you listen to them, different kinds of people, the more you try to talk about psychiatry with them, and the more you discuss, the more would be your ability to understand that, okay, what do you want to ask? I get it. And when you get it, and when you know it, you are able to precisely deliver what they want to hear from you. And that makes an impact and that makes a good presentation. So this is what all the soft skills goes into this, but ultimately it is very important and essential part of presentation. It's not just theoretical knowledge, it's not just knowing everything about history taking an MSc. This is equally important in the final recipe of a good case presentation. Again, time management skills. Yes, there is limited time to elicit the history, there is limited time to present everything. So, how well you manage this time to cover everything, to share everything that you know is a skill that you need to develop. Storytelling skills. Yes, a lot of psychiatric history goes in the form of a story. On one side, we follow a structure, a norm, headings, subheadings to switch one by one so as to have a complete understanding about the problem. We need to have a structure. Structure helps us to see to it that we are covering everything, we are asking everything, and it makes it complete. But at the same time, the way you narrate the history and examination can be made a very smooth flow of description or telling a story to the other person in a systematic manner that makes a very pleasurable or a very convincing impression onto the listener. Your presence of mind, yes. A lot of students they get confused, they are not able to focus on the questions being asked, they answer something else than what is being asked. They tend to give theoretical answers for questions which are very particular for the current patient being asked. So you need to have a lot of presence of mind when you are trying to interact with your examiner. Being trying to be comprehensive, yes, as I see and as you can see in my presentation, I've tried to cover various aspects of the patient. So you need to understand that when you try to understand and address, it is a complete package that you have to take as a whole. Lateral thinking, yes. Your ability to think about differentials require lateral thinking. Your ability to think about how a medical condition and the psychiatric diagnosis may be related requires lateral thinking. Your ability to understand that how life situations and stressors are related to my current presentation requires lateral thinking. So, what all other things may be present? So, very commonly in your presentation, when you come to a diagnosis, an examiner not happy with the diagnosis, or they think it's something else, and the discussion goes in a way that you try to justify why you believe that it is this condition. What is required is your ability to have a inductive or a deductive thinking. That can you expand this limited symptoms to seven possible diagnoses, or can you make a concise possibility of a single condition in which all the symptoms can fit into? So, how literally can you think about all possible situations, all possible things that can happen for this presentation? Is your ability to think laterally and is very important. List said about this. The last and the most important thing is overall your body language. If you look and if you sound enthusiastic and confident, a lot of things are done well in your presentation. So when somebody is sitting in front of you and trying to judge you as an examiner for your presentation, everything matters and everything goes into overall impression that you create. You should have a reason to believe for what you say, justification for every component of your history and examination. You should be clear why you believe that. But at the same time, it is important that in all your case presentations and for every case that you see, you may not be able to have all the information, and it's okay. What is important is the right approach to the case rather than the wealth or complete information about every aspect of this patient and the history. So do not worry if you're not able to gather all the information or if you do not have answers to maybe some relevant sections which you could not ask, you could not answer in the examinations. But even with that partial information or incomplete information, how do you make sense out of it? How do you comprehend? And what possible things can you imagine? And how do you plan? Suppose if you're given more time, in which direction and how would you further work in this case is your approach. That is what the examiner is interested in knowing. And that helps the examiner to be feeling confident and assured that you're going to be a good clinician later on. Thank you. Okay.
Thank you,
So
Dr. Shah.
shall I,
Yeah,
yeah, shall I stop my screen sharing?
yes, sir.
Okay.
That was indeed an absolutely comprehensive overview about such an important topic of history taking and mental skills examination. It was detailed yet crisp and giving a lot of clarity how to go about it, how which questions to be asked while gathering history, and how to assess the mental skills examination, and giving practical tips for exam going students, how to appear for the exam. That these are the very important, useful information and tips. I'm sure that students will definitely be benefited. I'll just check if there are any questions. There was one question by Dr. Dinesh Rohila that he wanted to know something regarding multi-axis diagnosis and depth or intensity of mood.
Yeah.
I
So
hope he's still
multi-issue
listening. Yeah.
diagnosis is, yeah, multi-issue diagnosis would be typically what we used to practice before is like axis 1, 2, 3, 4, 5. It's very easily available in the textbooks. You can refer to it. Typically, the axis 1 would be the primary psychiatric disorder. Axis 2 would be something like the defenses or intellectual functions or personality related issues. Axis 3 would be the psychosocial factors. Axis 4 would be the other neurological medical conditions. Axis 5 would be something related to the overall impairment or the level of functioning that you assess in the patients. So, this is one construct or a way of understanding the problem. That was an approach. Depth or intensity of mood would be something like the severity, or you can say like various grades of mood that you can discuss or describe using specific terminologies. Yeah. Any other question?
I don't think any other questions are there. I just wanted to know from student point of view, like while in exam, are they supposed to stick to particular guidelines about management plan, like NICE guidelines or IPS guidelines?
Yeah.
Because
So
many
there
times
is
they get
one.
confused.
Yeah. Yeah. So see, most of the teachers and clinicians, they know that there are multiple guidelines. Most of the teachers also know that there will be one set of guidelines being practiced and followed in their department, which they are used to, and they have worked and learned that. So we know that very well. We do not expect that they know everything, or there is no certain benchmark that is expected. What is expected is that one, they should be knowing the standard treatments which are given in standard textbooks, yes, which we all are abided to follow and know well. Second, one aspect is the clinical aspect, another aspect can be a legal aspect or an administrative aspect. So depending upon like whether I follow an ICD system, a DSM system, something like whether I have to record the medical history in a particular manner in my hospitals, whether I have to write down a discharge summary and give it to the patient, whether it's an online HMIS system, there can be variations in the format of the history taking examination as well as the management plans. But after the standard treatments in standard textbook, if the second line of know-how is expected, it is expected that that should be the national guidelines, or what does the laws in India would suggest to do in that situation, or what are the IPS national guidelines for management of those conditions. Third, it would be expected to know internationally established standard guidelines. Suppose if it's a nice guidelines which is being more taught, practiced in that department, it's fine. If they read that, it's okay. They should have a justification that for this treatment line of management, what is the basis? If they tell that, okay, this is as per the NICE guidelines, which I have read, it is absolutely okay. Yeah.
There is one question on abstract thinking. I don't know what does the person mean about it, whether she wants to know about abstract thinking or the questions to be asked.
Would the student like to come online and ask?
Aishwarya Avlekar.
Dr.
Yeah.
Aishwarya Avdekar, how to explain? Okay. Okay.
Student has asked
Let us go to the.
how to explain,
Yeah.
sorry, yeah, how to
Yeah.
explain temperament of below 18-year-old child.
Hmm. So this can go as a typical middle childhood history or adolescent history. It can go in the form of pre-morbid personality. It can go in the form of overall assessment of the temperament if in case the patient himself or herself is an adolescent or a child. So just as I have narrated and enlisted different kinds of terminologies that we can use, even for the temperament, there can be various terminologies that we can use and understand when to use and find an appropriate term for that. Uh, Grossly, the temperament would be something which we try to refer to reflecting and matching with the personality traits or personality types, which defines the major predisposition of that person. But there can also be a lot of other temperament related terms that can be used to discuss the child's behavior, overall exhibits that the child has. So it would be something like kind of most of the time, consistently for a long period of time, is there a kind of a habitual pattern of relating to others or behaving or expressing emotions in front of others, especially in interpersonal settings? That does gives us an idea about describing the temperament of that person. As I said, try to make a list. Try to make a list of adjectives and proper nouns with an understanding what do they mean. In case if your patient or the child does not fit into any one of that, but you have observed something, you can then use a kind of a common English language word to describe what you mean to say. Another question is, should we write the history of present illness day wise or symptom wise? Uh, there can be different methods. I would recommend going for symptom wise because a lot of teachers and examiners would be appreciating that pattern. Abstract thinking questions to be asked for it. Yeah. So there are a lot of things, a lot of suggestions which we can find in standard textbooks, which helps us to understand that how do we assess the abstract thinking. Something like there are practices of asking proverbs, there are practices of asking some kind of similarities, dissimilarities. There can be other ways of assessing abstract thinking. But one message from my side, very clear for this, is that do not go for same question. Every student asking same question to every patient every time that probably you have done for 3 years and you do it even in the exams. Don't do that. We are bored of listening to the same questions to elicit abstract thinking, checking it time and again. Please find out new questions, new scenarios for assessing abstract thinking, for assessing judgment, and other things for assessing the knowledge, the intelligence. There is a wealth of questions that you can think about and try to practice. Okay. Day wise, like a story describing the progress of symptoms or just explaining symptoms in chronological order. Okay. So, usually it is expected that when you begin your chief complaints or OD, first you just enlist the different kinds of complaints that they have, and then you go for the origin, duration, progression of each symptom into the detail. How to do mental status examination of uncooperative patients? Okay, a very important message in psychiatry for a lot of diagnosis and for a lot of different kinds of patients. You may have a patient who is not responding, not wanting to talk to you, is basically uncooperative because of the psychopathology. You may have a patient who is alone and no family, and then you cannot have a complete history. This kind of things are expected to happen, which can lead to gaps in history or mental status examination. It is okay. When you tell the examiner that only patient was present, or when I asked about this questions, patient did not respond. The examiners would also be probably having the patient in front of them to see that yes, there are reasons why patient did not respond. They are convinced. It is sufficient for you to express that you know that what you are supposed to ask. You did ask, and attempted, and this was the response. No response. And that's fine. The examiners would then go to other sections to judge that how well you can go further if at all the patient would have responded. In mental studies examination, I would say that there is nothing like leaving anything blank or having no remarks about your observations. MSE is all about observations. So when you ask questions and patient has not uttered a single word, even that is an observation. A positive observation. A positive thing to report and discuss. Absence of response is not absence of observation or mental status examination finding. Because if you have a patient who has not responded, who has not answered, who has remained mute, it is a very significant finding that you are telling to the examiner in your examination. So please feel free and confident when you tell the MSc in such a patient that what you asked and what response was received. And also, no response. How do you infer that situation? What is your judgment about why patient did not respond? Is it a part of the psychopathology or something else? Is what the examiner is interested in knowing. Okay. If we start history from describing person before appearance of symptoms, then same thing would be repeated in pre-morbid personality. Is it not so? Usually, we do not discuss the person in initial sections. What we discuss is the gross, concrete, objective information about the person. Like, how do I locate? How do I identify? What is the overall presenting scenario? Who is coming with them? From what section of the society? Domicile, background, socioeconomic, familial, and other things are there. So as to have a baseline that, okay, this symptoms and disorders are happening to whom? When I talk about the pre-morbid personality, it is a qualitative description of a human being, especially with regards to their mental abilities and descriptions about their behavior, their mood, their overall attitude, and other aspects of their mental health and lifestyle that I'm trying to discuss in my pre-morbid personality. The purpose of pre-morbid personality description is to have an idea, an in-depth idea that today what I am seeing as a patient in front of me, the presentation is completely colored by the symptoms. What he says, the way he behaves, what he expresses is not he, it is the symptoms or the disease. I am interested in knowing what this person was to begin with as a human being. So that's a pre-morbid personality, describing qualitative aspects of that person when he or she was normal, absolutely. Because there are variations in normality. So if I know that this person, when he or she was normal, was this kind of person, I know that is the baseline for that person against which I compare the current symptoms, the deviation and the derangements in their behavior, the mood, and other aspects of mental health that I compare and contrast. Also, I know what should be my goals of treatment. That if I give the treatment and if the patient improves completely fine, one fine day, what do I expect to achieve? I expect them to achieve the pre-morbid levels of functioning and personality. So I need to know what it is all about. Okay. Then comes the history. Okay. In history, you have mentioned about legal history. Can you elaborate more about it? Yes. We very well know that psychiatry, social functioning, and legal functioning are very closely associated with it. It is important as a psychiatrist for us to inquire into the legal aspects of the person's life because I can have a patient of schizophrenia who may have had conflict with law in past. I can have a patient or who was like having a problem because of their psychopathology with people around. I can have a patient with opioid use who can also have an antisocial personality or behavior which has a close relation with their primary psychiatric disorder. I can have a person whose impulsivity may have landed them into legal trouble, or high risk behaviors may have landed them into legal trouble. If you go to a prison, if you talk to people who are punished or convicted of various crimes, you would see that they have varieties of psychopathologies contributing to their legal problems. On the other side, we see that a lot of our patients in everyday practice, many a times, they come in close contact with the legal system because of the psychopathology or other reasons. And the association is very important for us to know. Suppose there was a fight, there was a quarrel, and there is a history of trauma. You can examine the patient and you can see that, okay, you need to register a medical legal case right now. It becomes relevant for you to understand what has been the past legal history of this person. So it makes sense. The social domain, the clinical domain can be correlated with the legal history. Okay. How to describe attention in mental status examination?
I think all those parameters are given in the various
Yes,
questionnaires.
so standard questions, I think standard assessment methods you can very well read in the textbooks. They are there in depth in almost all standard reading materials. Okay.
So thank you, Dr. Shah, for giving excellent talk on such an important topic. I'll hand over to Dr. Ashmin for the concluding remarks.
Thank you so much.
Thank you. Thank you very much, Dr. Shah, and thank you, Dr. Kadam. And it was, as expected, a brilliant discussion, a brilliant talk. Very simple, very lucid, down to the basics, as my teachers would like to tell us. And sometimes that's what is required. You need to go down to the basics and be able to help our postgraduate students understand things from the very basic building blocks of how we understand psychiatry, how we practice psychiatry, and how we teach psychiatry. So thank you very much, Dr. Shah. It was really a very, very delightful and lovely presentation in its simplicity as well as in its lucidity. So thank you very much once again. And thank you, Dr. Kranti, for making the time and being with us and
It was
doing
all
the
my
exemplary
pleasure.
job
Thank you.
and taking this forward. And of course,
Thank you so
thank you
much.
all the postgraduate students who have stuck around, who have peppered us with a whole bunch of questions, very interesting, very inspiring, and some of the faculty who joined us as well today. And of course, unflinching support by Sun Pharma to this academic venture. So I express my gratitude to them as well. And we will see you again next month. Another interesting talk on the DY Patil Postgraduate Lecture Series. I wish you all a great evening ahead. Thank you very much once
Thank
again.
you. Yeah,
Thank
good
you.
night.
Thank you.
Bye.
Thank you. Have a
Thank you
nice
very
day.
much.
Yeah.
Thank you.
Goodbye.
Bye bye.